Good morning, everyone. I am Rahul Gosain,
And I'm Rohit Gosain.
and we are Oncology Brothers. Today, we have the pleasure to welcome Dr. Maryam Lustberg, who's a Chief of Breast Medical Oncology and the Director of the Breast Center at the Yale Cancer Center. She's also the current President of the Multinational Association of Supportive Care in Cancer. In our discussion with Dr. Lustberg, we'll focus on 3 breast cancer studies from ESMO 2022 and how these studies are shaping our community practice. Let us welcome Dr. Maryam Lustberg.
Thank you so much for having me. Great to be here.
Thanks so much, Dr. Lustberg, for being here today. Let's dive into our first study, Monarch III. Previously, we have had the data on palbociclib and ribociclib. Can you please walk us through the recent update on abemaciclib, another CDK4/6 inhibitor, and your take on this data?
Yes, of course. So we're fortunate that we have 3 approved CDK4/6 inhibitors currently in practice, which we are able to use for patients with hormone receptor positive metastatic breast cancer. Abemaciclib is also currently approved for high-risk adjuvant setting in hormone receptor positive breast cancer. So Monarch III, this is an additional interim analysis of overall survival data in patients receiving this particular CDK4/6 inhibitor plus an aromatase inhibitor who were postmenopausal. And we are seeing a clear overall survival advantage. The data are not fully finalized, but clearly there is an overall survival signal. So the significance of these findings are that 2 out of our 3 CDK4/6 inhibitors, both abemaciclib as well as ribociclib, are showing an overall survival advantage when we're using them in this early metastatic hormone receptor positive line. Part of what was reported in both ASCO and ESMO and has been part of ongoing discussion is that we're not seeing the same overall survival advantage with palbociclib, which was the first CDK4/6 inhibitor approved. So there's been a lot of debate about what is the optimal CDK4/6 inhibitor to use. Clearly, they all have progression-free survival advantage. But given that 2 out of the 3 agents are showing overall survival advantage, I think many of the breast oncologists are changing their practice and tending to use less palbociclib and more agents that are showing overall survival advantage, and that would be ribociclib and abemaciclib.
Dr. Lustberg, in your practice, given this data, if you have a patient that's sitting in front of you with a newly diagnosed metastatic breast cancer, would you also be leaning towards abema or ribociclib in those settings?
Yeah, I was, when these agents first came into the market, I, like many oncologists, have felt the most comfortable prescribing palbociclib. I think in many ways its toxicity profile is a bit easier to manage. However, since the final analysis of Paloma 1 and 2 for palbociclib continued to show no overall survival advantage, I have changed my practice to try ribociclib as the initial CDK4/6 inhibitor. It has some challenges, including the need for QTC monitoring and LFT monitoring that we were not seeing as much, with palbociclib. Abemaciclib is also a reasonable agent, but it tends to have more gastrointestinal toxicities and diarrhea. So for that reason, it's not my go-to first agent to use. But certainly, as you can see with the results of Monarch III, it does have good activity with both progression-free survival and overall survival advantage. Let's say a patient had already a borderline QTC or some LFT abnormalities, perhaps I would start with abemaciclib in that situation.
Thank you. And do you see a strong need in the community if a patient is tolerating palbociclib well, a need to switch them to ribociclib or abema in that case?
I think we have discussed this across multiple circles, and I can definitively share with all your listeners that as a community, we feel strongly that patients should not be switched if they are tolerating palbociclib and having a response to it. So we feel confident in kind of giving a consensus opinion there.
Perfect. Thank you for sharing your thoughts on that. While we're on the topic of CDK4/6 inhibitors, let us now look into our second study, ELAINE-1, which tries to answer what to do once we've progressed on CDK4/6 inhibitors. Dr. Lustberg, can you please discuss the study design and its finding for Lane 1?
Yes, so I think this is, as your listeners can attest, what happens after progression after CDK4/6 inhibitor has been a huge clinical challenge. When typically the standard thing is to check for a PIK3 alteration, and if it's present, patients go on to fulvestrant plus alpelisib. But if they don't have an actionable mutation, essentially for many patients, they go on to receive fulvestrant monotherapy. So in this particular study, fulvestrant was compared to a novel selective estrogen receptor modulator, which is lesifoxifene. And the results are not the most important part of this study. What it showed, though, is the clinical challenge that we're seeing in our population is that most patients are not responding to either agent, is the truth. Essentially, there is a rapid progression-free survival drop-off. Many of these patients have ESR1 mutations, which make them resistant to aromatase inhibitor therapy, and there are even some alterations that make them even resistant to fulvestrant. So the take home of this study was not so much that, oh my gosh, we have a new agent that's going to be helping us, but gosh, we really need to be looking at combination studies. That fulvestrant alone is not going to do it. SERMs alone are not going to do it. SERDs alone are not going to do it. We need to think about targeted therapy combinations, and that may be in combination with CDK4/6 inhibitors. It may be in combination with other agents, because this second and third line endocrine therapy setting is quite challenging. And so the makers of this drug are actually mounting a large phase 3 study coming up. Well, they'll be studying this agent with in combination with abemaciclib in a phase 3 setting in comparison with fulvestrant.
Thank you so much for going over that. Dr. Lustberg, in your clinic, what is your workflow? When do you order, in fact, NGS testing? Do you often rely on tissue biopsy or feel liquid biopsies, in fact, adequate?
I think for if we could have reasonable tissue that could be tested, I prefer tissue, but certainly with bone biopsies can be quite challenging, or patients may not have enough tissue that could undergo a next generation sequencing. So I think in those situations, I think liquid biopsies are absolutely reasonable. From the SOLAR-1 study, which looked at PIK3 alterations, we saw that there was a portion of patients where it was not able to be detected in the liquid biopsy, but could be detected in the primary tissue. So I would not stop if you have a liquid biopsy that is not showing a certain alteration. I think tissue is always better in some ways, more reliable, but certainly I do use liquid biopsy. They're more convenient for patients, and it has the option of perhaps getting more serial testing done, which may identify additional targets.
Thank you. Now let us look at Tropics II update presented by Dr. Hope Rugo. Where do you see sacituzumab fitting in your treatment algorithm, and how would you sequence this in the recent approval of TDXD in low HER2 positive patient population?
It's such an important question, and I think we're still trying to figure this out. It's great that we now, the FDA approval for sacituzumab for hormone receptor positive breast cancer is pending, but should be forthcoming soon. As your listeners know, this agent is already approved for triple-negative metastatic breast cancer. And I think with the findings and publications, I think if there's a patient who needed sacituzumab with hormone receptor positive breast cancer, I think it's possible to get the agent even now, depending on insurance status. But back to your more important question is, now we have 2 antibody drug conjugates that we could potentially use in hormone receptor positive metastatic breast cancer. And with TDXD or HER2 being approved for HER2 low, I think the study investigators for Tropics II really asked the question, is there any difference when we have a differential HER2 signal? So what kind of activity are we seeing in patients who have a HER2 low signal or HER2 IHC 0? And really what we saw in this study is that you're seeing benefit across all HER2 varieties. So it's not so much that the HER2 signal is necessarily going to help us decide what to use. When I talk to different physicians, they're choosing differently. Some prefer to have the HER2-directed ADC T-DXd as the preferred second line, based on the idea that we know that patients who have been less heavily pretreated tend to have less toxicities from HER2 ADC therapy, less complications of interstitial lung disease. At the same time, you do have interstitial lung disease, which is associated with about a 2% mortality. So I can also see the flip argument of you have a phase 3 study with sacituzumab that is showing an overall survival advantage, which was an important finding here. So I think if I have a more frail patient who may have some lung comorbidities, I'm more likely to choose sacituzumab as kind of that second line agent, and perhaps save T-DXd for the following line. To be honest, I think there is a lack of clarity. We don't have a comparison between the two agents, and that study probably will never get done. So I think we'll be relying on real world practice to see what outcomes we're going to see in the real world in terms of how different oncologists are going to sequence these agents. What I would leave you with is that it's great that we have two agents that we can use. I would promote kind of thinking about it on a case-by-case basis, and also how your patients even kind of conceptualize risk. And I think obviously they need to be informed of the ILD risk and the small risk of mortality with trastuzumab deruxtecan. Sacituzumab tends to have more diarrhea symptoms, GI symptoms. Both tend to have hair loss associated with them. I think the big differential is honestly the interstitial lung disease and how that risk fits with other competing risk factors for each patient.
Dr. Lustberg, in this particular study, the patients were more heavily treated than what we saw with T-DXd as well. So I think that's also
yes, that's
important.
A very important point. Very important point. And the fact that, sometimes people are doing cross comparison study differences of saying, gosh, the progression-free survival or the overall survival in the sacituzumab study was so small, but with trastuzumab deruxtecan, it was certainly larger. But as you said, very different populations in some ways, and kind of those type of cross-study comparisons are not very valid, as we all know.
Given the overall survival benefits seen in this study, we'll be eagerly waiting for FDA approval.
Yes, it's likely will happen. Yes.
Dr. Lustberg, thank you so much for taking the time to discuss these practice-changing studies with us today. These highlights will give our community oncologists a chance to stay on top of this rapidly changing and evolving field. Thank you so much again for your time.
Thank you so much. Thank you for having me.